Hello everyone, my name is Jeanne Saw and I've been working with Myopia Profile for over 2 years now, and I'm Manager of Professional Affairs and Partnerships. I am also a qualified optometrist and I graduated from the University of New South Wales in Sydney, Australia in 2020 with a Bachelor's in Vision Science and a Master's in Optometry. Now today's topic is one that I think is really important. It's definitely something that I've encountered before in clinical practice, and I'm sure you have too. It's progression and success in myopia management. So there are two ways to measure myopia progression, and that's refraction and its axial length. Let's consider how they're different. So with refraction, it gives you immediate feedback on vision, meaning you'll know what a patient's visual function is like based on the magnitude of their myopia. All eye care practitioners can perform this, and it is highly correlated with axial length as well. It can be variable though, and to get the most accurate refraction, you'll have to cycloplege your patient. Axial length, on the other hand, is very accurate, it's very repeatable. It also has the advantages of being rapid and contactless. Cycloplegia isn't required, and it does give an indication of future risk of sight-threatening eye conditions, which arguably is the most important aspect of myopia management. You do require an optical biometer though, which may not be accessible to everyone. It does require you understand how to interpret axial length data as well. Now, measuring myopia progression using axial length definitely has a lot of advantages. It may very well become the standard of care in the future, but no matter what you have access to, you can and should still provide myopia management to all your patients. The goal of myopia management is to slow down progression. So it becomes really important to understand how much progression is normal and how much progression is too much. The Myopia Profile infographics provide us with an easy way to assess progression. On side 1, we have the parent communication process, which can help you explain why it is important to slow down progression, which is detailed on panel 4. This goes over the long-term and short-term goals of myopia management. On side 2 is the practitioner chairside reference. Panel 4 here goes through assessing progression. Let's take a closer look at panel 4. So the first part of this infographic shows you how to assess progression based on refraction. This part here is how effective we are expecting their myopia control treatment to be based on the efficacy of the treatment you have given the patient. This not effective panel on the right shows the amount of progression we would expect if they were not given any myopia controlled treatment at all. So if we zoom in on this a little more closely, then you'll see what we mean by no treatment is giving a patient single vision correction. It's a useful starting point when discussing myopia control with patients, as it allows comparison with effective treatments, and it also provides some context as well. So you see here, in a child that is less than 9 years old, you would expect them to have an annual progression of 1 diopter. Progression will slightly slow down to 0.75 diopters per year in children 9 to 11 years old, and then in children 12 to 16 years old, you would expect 0.5 diopters of progression per year. Compare this to the age ranges within the other categories. So the best slows down myopia progression by half, the next best slows progression by about a third, and the less effective provides minimal slowing of progression. So you'll see that a child that might have progressed by 1 diopter if they hadn't been given any treatment at all would progress instead by 0.5 diopters per year if they were given the best treatment. Now, what might that actually look like for a child in a clinical setting? If we think about the short-term benefits of myopia control, one of the main benefits is better vision in between visits and also unaided. So let's say we have a patient called Lisa who is 7 years old. She's a -1 diopter myope and she's only given single vision glasses. Over a year, she would have progressed by the average amount of a myopic child her age, which is 1 diopter, and by age 8, she would be a -2 diopter myope. Now, of course, ideally, we would be following up on Lisa every 6 months rather than a year, in line with IMI guidelines, so hopefully we would have caught this earlier. But for the sake of illustration, let's just say we saw her a year later. Now, in the case she is given a myopia control treatment that slows her progression by half per year, then instead of progressing by 1 diopter, she would have only progressed by half a diopter, and by age 8, she would be a -150 diopter myope. So in the first scenario, with the single vision glasses, Lisa's presenting aided acuity with those glasses she got when she was 7 years old would be around 618 or 2060, which actually meets the level for vision impairment based on the World Health Organization criteria. Whereas in the second scenario, her presenting acuity with myopia control glasses or contact lenses she got a year ago would more likely be 69 or 2030, which is substantially better. And it's also a very different visual experience to being essentially visually impaired. Of course, it would be an easy fix with a simple prescription change, but that is what her visual experience would have been like. So it's very important to understand that by slowing down progression, we are also preserving visual function between visits as well. Of course, not only are there short-term benefits, but there are also long-term benefits of myopia management. We can see here in the graph that with increasing magnitude of myopia, we also see an increase in the prevalence of myopic maculopathy, and this is across multiple regions. Every 1 diopter increase in myopia increases the risk of myopic maculopathy by 60%, or you can say every diopter reduction in myopia reduces the risk of maculopathy by 40%. So back to our infographics. If you notice progression is on par or slower than this is a great result, meaning you can continue with the current treatment and you're likely to save at least 1 diopter. If progression is around this rate though, then this is a poor result and you'll have to look into strategies to reduce progression. We've spoken a lot about monitoring myopia using refraction, but what about axial length? Axial length progression is covered in this box here. So let's take a closer look at that one now. You can see that for a 7 to 10-year-old emmetrope, they would experience growth of around 0.1 or 0.2 millimeters per year, whereas an untreated myope of that age would grow around 0.3 millimeters, which is around double. An older emmetrope, around 11 to 16 years of age, would continue to have growth of 0.1 millimeters per year, whereas an untreated myope would experience 0.2 millimeters of axial length growth per year. Some axial length red flags to be aware of is that the fastest growth for a myope will occur 1 year before myopia onset. The CLEAR study found that future myopes grew by 0.33 millimeters in the year prior to onset, slowing down to 0.2 to 0.27 millimeters per year after onset. So make sure to follow up closely on those that you suspect to be pre-myopes if you notice this amount of growth. The CLEAR study also found that growth of 0.22 millimeters in a year was a way of identifying fast myopia progressors, regardless of their previous refractive or axial length history. Therefore, if you note this amount of axial length growth, ensuring appropriate follow-up schedules and providing the best interventions is especially important in these cases. The average axial length at myopia onset is 24.1 millimeters for boys and 23.7 millimeters for girls. So if you observe axial lengths approaching these figures in girls and boys, then you can predict that myopia onset will begin soon and give advice on myopia management. So an easy way to gauge the success of your myopia management is by looking at the colored regions on the infographic. Observing eye growth in the green zone in a myope is a good result, because it means that the treatment has brought the myope to the same growth rates as an emmetrope of the same age. If you see growth around the yellow zone, this means that there is poor control of myopia. You might want to consider factors related to efficacy of the treatment, and so asking questions about compliance, full-time wear, time spent outdoors, that sort of thing is a good idea. The red zone donates an axial length of 26 millimeters or more, which comes with an increased risk of sight-threatening eye conditions. We want to keep axial length to below 26 millimeters. You can learn more about using axial length to measure progression in our article, How Much Axial Length Growth is Normal? Or you can learn about the other ways you can use axial length data in our article about growth charts. Another important question to consider is, how often should we check for progression? You might have noticed on our infographic in the follow-up schedule panel that after a treatment has been established, the International Myopia Institute recommends 6 monthly reviews. However, with rate of progression we just covered, it's looked at every 12 months. Now, why is that? This is because rate of progression can change throughout the year as the seasons change. A study based on Chinese children found that mean progression in summer was 0.31 diopters and 0.17 millimeters in axial length, which was comparatively slower than in winter, which was 0.53 diopters and 0.24 millimeters. It appears that you might expect a faster rate of progression in winter than in summer. Why might that be? So the reason why there is seasonal variation is because typically during the summertime, children are spending more time outdoors. In many parts of the world, in fact, summer also coincides with vacation times, which would also mean fewer hours in school and less time doing near work. It has been speculated also that there are seasonal differences in the spectral composition of light as well. Hence, if assessing progression, it is best to do it after 1 year, although it is still important to check every 6 months per IMI guidelines. One more thing I'd like to cover is young adult myopia progression. Now, you might think that progression is something we only need to worry about in children and teenagers, but according to research presented at ARVO 2024, young adult myopia progression can also occur. In this study of 18 to 25-year-old students, they found that 1/3 experienced axial length growth, and increase was greatest in the winter. In this study, they found that while the majority of adult patients had stable myopia, non-stable myopia was highest in younger patients aged 18 to 24 years old, which came to around 23.4%, and high myopes over 6 diopters, which was around 20%. Approximately 8% of adult high myopes showed fast progression of at least 0.5 diopters per year. So it's important to note that myopia progression is common and should still be checked for in the young adult population, so make sure not to neglect this demographic. The bottom line is that when we reduce myopia progression, we reduce the risk of sight-threatening conditions later in life, such as cataracts, retinal detachment, and myopic maculopathy, as mentioned before. Saving 1 diopter might not seem like much, but we have to remember that no amount of myopia is a safe amount, and slowing progression by as much as we can is the key here. To summarize, you can use our free Managing Myopia Guideline infographics to help you monitor and assess progression. Remember that after 1 year, we usually assess progression to account for seasonal variation. And finally, young adults can progress as well, so ensure you are following up on them too. Thank you so much for listening, and I hope you enjoy the rest of the Myopia Action Month lecture series.